This lecture is on posture, gait and ataxia. So there are number of objectives and I'm trying to cover this from this lecture, and I hope you will do further reading as well. So to start with the lecture outline, which I think is easier though, so that you know what is the flow of this lecture, which will be an aid for you to understand. So I'm starting with the posture, then going to gait, and then going to discuss about ataxia, right? So for the posture part, I'm going to discuss what are the tissues and organs important in maintaining posture, and then a bit about the importance of stretch reflex. And mind you, I'm not going to go into details about stretch reflex because you have done it in details during reflexes lecture. But what you have to understand here is mainly the role of alpha motor neuron in maintaining posture, right? And then though it's not very related to the posture, still I'm going to details about lesions in motor system. You know, the main classification of upper and lower motor neuron lesions. And then there are two most important pathological postures, right? Other than after discussing about the physiology of posture, there are two pathological postures I want you to concentrate on. They are decerebrate posture and decorticate posture. And what is the pathophysiology behind them, and what are the features of them mainly. And then I will tell you at this point what's the importance of knowing about posture. You might wonder what is the relevance of knowing about posture clinically. You know, there are certain people who can't maintain their posture properly due to various neurological diseases, right? Especially elderly people, they are coming with frequent falls. Population worldwide is aging, and there are so many admissions with falls. So as doctors, it is mainly important to have an understanding about the things that are helpful to keep the normal posture. So any defect in any kind of the factors which affect posture would result in inability to keep the correct posture at the correct time, and will result in falls, right? Or instability in movement. So that is why we are learning about posture. And then the gait, gait is extremely important. Just certain neurologists, they're capable of just asking the patient to walk around, and they can diagnose the disease just the way they are walking around with their walking pattern. And at your level, it's very important to have a basic idea about the gait and what is the physiology behind that gait. And then what is meant by ataxia. So ataxia have different types, and then just the basic idea how to assess ataxia, and where the lesions can be found in ataxia. So it's basically a very not in depth, but the basic factors and the important subject matters will be touched in the lecture, which will be an aid for you to understand these topics in future.
To start with this question, what is posture? So it is the position of the body in the space, right? And you know, it is sustained by the constant adjustments by the musculature in response to shifts in gravity. You know, if you're standing, the way the gravity acts on you is quite different for how the gravity would act on you when you're sleeping, so that the musculature, the muscles of the body, muscles around these joints, other muscles, they all have to maintain your posture against this gravity, right? So we are going to learn how this is done by the body. So these are different body postures, and they need very structured command to handle the activation of different muscles in different areas in the body. So it is by influencing muscles to contract or relax, the posture can be maintained. So for this function to happen, right? So that is the ultimately what should happen. Ultimately, the last point or the final common pathway where it tends is just contracting or relaxing muscles, and the motor neurons should play a role. And then however, for the motor functions to happen properly, there should be several sensory inputs, right, coming through, and then there are a series of reflexes, and central nervous system should integrate as well, and so just not maintaining the posture, you're changing the posture all the time, which would result in what is called movement. So the most important postural reflex is the simple reflex that you know, the spinal reflex, that is the stretch reflex. Stretch reflex, while maintaining the posture, keep the tone of the body as well. You will learn what is tone later. So to keep the upright posture, tone is important. And all these postural changes are triggered by the information from the sensory receptors. Okay, what are these sensory receptors? So that is only one part of the whole system of tissues and organs that are important in maintenance of body posture. So sensory system is just one part of that, but it is one of the most important parts. So the vestibular organ, right? Vision, proprioceptors, sensory receptors, mainly in foot soles and hands, are really important. As well as in the central nervous system, motor, frontal and prefrontal cortex, brainstem and spinal cord, and then cerebellum, which is trying to coordinate all these things, and the motor system. So what are proprioceptions? Just take, for example, your thumb, right? And fix the thumb from the interphalangeal joint there, right? Fix it from that position, and just move it up and down from there, right? Once you closed your eyes, when this movement happens, you know where your thumb is. Okay, it's going up now. and it's coming down now. You have an idea where your finger is, where your joint is, and where your phalanx is going, whether your phalanx is going up or down. You have an idea. So that is that you know where your joint and where your position, right? So for proprioception, the most important sensory receptors located at, muscle spindles, tendon organs, joint and skin, right? So they act as proprioceptors. So what they do is they senses the posture and movement of body segments relative to each other and send that information. So this is the main proprioceptive organ that we are talking about, muscle spindle. I'm not going into details about muscle spindle. I think you already know. The changes in muscle lengths are associated with changes in joint angles, right? So muscle spindles provide information on position because they can sense the change in joint angles. So the vestibular system, right? So it can sense linear and angular accelerations of the head. I'm not going into details because it's a different lecture. And the afferent connections which carry this information run mainly to the cerebellum. They can go very straightly from the vestibular system directly to the cerebellum like this, or maybe going to the vestibular nuclei and then can go to the cerebellum. As well as vestibular nuclei also connect to the thalamus and to motor neurons of the eye muscles like this. You can see these are the nuclei of the eye muscles, 3rd, 4th and 6th, which is responsible for the eye movement, as well as to the skeletal muscles. You can see it's going to the 11th nerve nuclei as well as to the spinal neurons of the skeletal muscles, because it helps to provide a very fast feedback. So if you when you know that your head is just bent towards one side, just think about that. So you want to correct it back to the straight position. Then what should I? So your say your vestibular system sense that, right? And then your neck muscles should work accordingly. That is why the information is going to the neck muscles as well as the eye movement occurs at the same time. So this system is trying to maintain the posture. And the other important thing is vision, which is continuously giving you information about your posture. Vertical, horizontal, references, linear and angular accelerations of the head, and any potential balance state, something is coming towards you, or you are not in a proper place, your legs are not very, you can see that your legs are not in a proper balance, right? And all these things are connected to thalamus and midbrain, mainly from optic nerve. So all these sensor system impulses are transmitted via afferent pathways to the central nervous system. And central nervous system's responsibility is not to think about just one impulse coming towards the way, and to look at all these stimuli as a whole. Okay, the proprioceptive organs are telling this. The Golgi tendon organ at this place is telling me this. And also the sensory receptors on the big toe of the leg is telling this. And visually that I can see this. And the head is moving here and there. It can be sensed by the vestibular system. And Central nervous system has to integrate all these things and has to generate a command that should descend thereafter. So, the cortex play an important role, mainly concerned with voluntary activities that you do with your consciousness. They are mainly planned in the brain. And also, you should be aware that they are then go through the corticospinal pathways to the correct place. And corticobulbar system, what is corticobulbar? That is the motor cranial nerves, upper motor neuron. We usually call them corticobulbar neurons. So cerebellum is mainly concerned with the coordination, and it receives thousands of sensory information from different places regarding the state of body as well as about the environment. So vestibular systems is sending impulses, proprioceptive impulses, auditory visual impulses from motor and other parts of the cerebral cortex. So cerebral cortex motor part is also sending impulses, while all the other these places are also sending impulses there, and they are like cerebellum is trying to adjust the motor activity based on that information. So cerebellum plays a major role. So it is cerebellum's role to keep the movement smooth and coordinated. As well as there are some connections with basal ganglia in the body, so that it is extremely helpful for the motor cortex and premotor cortex to organize and plan the voluntary movements. And the cerebellum projects mainly to the brainstem, and from brainstem starts the tracts which comes downwards to the spinal level, and they are mainly helpful in controlling axial and proximal limb muscles, which are the main muscles involved in posture control. So in this picture you can see the brainstem pathways. So brainstem pathways mean the start of the neuron is from the brainstem, right? And then it descends downwards up to the spinal level. And at the spinal level, as you know, it is going to it is going to have an interaction with the alpha motor neuron. So what can you see here? You can see some fibers, they descend more medially, like the fibers that you can see here. You can see the tectospinal tract, reticulospinal tract, they are coming more medially, as well as there are certain tracts which are coming more laterally, like this. The rubrospinal tract, starting from the red nucleus, they are coming more laterally. And as a norm, it is found that the more medial fibers running over the brainstem and spinal cord, they are controlling the axial and proximal muscles, which are mainly concerned with the posture. But these fibers, which are going more laterally, they are concerned about the distal muscles movement. So here, these medial fibers, they are going to control the posture mainly. And some of these fibers or these descending tracts you might already know. One is reticulospinal tracts. So reticulum is a very complicated meshwork of neurons with certain nuclei, and situated in the brainstem region. and it has multiple tasks like sleepiness, wakefulness, and movements, coordination of movements. So plenty of tasks which have not been very clearly defined as well. And so there are tracts coming downwards from reticulum towards the spinal levels, as well as the cerebellar fibers are also uh, some are terminate at this reticular at the reticular regions. And vestibular spinal tracts that you already know, that is concerned with which are coming from the vestibular system. And tectospinal tracts are the one which is helpful to control the vision and the muscles, right? For example, even vestibular, tecto both. If there's a need of changing the neck according to the visual stimuli or the stimuli on the vestibules, then the next muscle should be supplied and the next muscle should get the correct impulse to do that. So that is the importance of having these tracts which are starting from the brainstem, because brainstem, you know, it carries all these nuclei of these cranial nerves, right? From there, these tracts are descending. And next is this picture, which is trying to summarize all the things that we have discussed so far. So it is a very clear picture that you can see that this says that this is the sensor information. And we have discussed that vision, vestibular system, and the proprioceptions, right? We discussed about muscle spindle, and the other sensory receptors. So all these things are going to give sensory information, not just one. All these things at the same time giving like different stimuli, and they are going to the central nervous system where they are integrated, right? The information, uh, uh, the integration occurs, and then out comes the motor response. So the cerebellum, central nervous system, they decide which type of motor response should be there according to this sensory information, and will ultimately uh, will result in contraction of certain muscles, relaxation of certain muscles to keep the body posture according to the sensory stimuli here, right? So it's kind of feedback loop with minor adjustments, major adjustments, and it is happening all the time uh, when somebody is active, because when someone is changing the posture, all the system would get activated and will result in the desirable posture and desirable muscle contractions or relaxations. So what would determine the outcome? It is the activity of the final common pathway, that is alpha motor neurons, which are going to do the task. So alpha motor neurons, you know, there are so many endings will come and uh, synapse with alpha motor neurons, and they function mainly for three main tasks. What are they? To induce voluntary activity and to adjust body posture and to make movements smooth and precise. So alpha motor neurons are there to do all these things, to do the voluntary activities, to adjust posture, and also to make movements smooth and precise. So not only alpha motor neurons which are funneling all this information, gamma motor neurons are also there. They also regulate in the same way. As well as these excitatory and inhibitory inputs are not only coming from uh, central nervous system, brain stem region, cortex, cerebellum, and also tectospinals, reticulospinal, not only from these areas which are coming from higher up levels. It is also need to be adjusted according to the interneurons from other levels of the spinal cord, right? So after all these things are integrated there, the alpha motor neurons will show its will show its impulse, what it would do. What will be the outcome, whether it's a contraction, relaxation, something in between, adjusting the tone according to that. So these things will be done basically by the alpha motor neuron. So these are the long descending tracts, and different efferents are coming, and these efferents can be either stimulatory or inhibitory in nature. For example, if you think about the impulses coming from the cortex through corticospinal tract, so they are usually thought to be inhibitory. So this is the alpha motor neuron, which is going to do the stretch reflex mainly. And you can see nicely there are inhibitory impulses as well as stimulatory impulses. So as I told you before, if you just, for an example, if you take the cortical impulses coming as corticospinal, from the corticospinal pathway, they are usually inhibitory, right? So you will learn later, if there's a stroke, that is a reduction in blood supply to the cortical area, which results in infarction of the cortex, would result in spasticity or increased tone, right? You will learn the reason later, which I will make sure that I will elaborate on that later. So that is because this inhibitory nature for the contraction is diminished. So there will be an unopposed type of alpha motor neuron discharge, causing more contracted state than usual. So usually when the higher pathway is resected, say all these things are resected, still inhibitory part is more prominent. So what we lost mostly is the inhibitory input. So knowing about muscle tone is important because you will learn with time that simply eliciting the muscle tone of a patient, you can get a lot of information regarding their neurology. For example, whether they have an upper motor neuron lesion, lower motor neuron lesion, or whether this problem or issue is in any kind of basal ganglion regions. So these information can be assessed by just checking the tone. So what is tone? Tone is the resistance of a muscle to stretch. So you can simply elicit in one of your family members today, or maybe one of your friends. Just hold their hand and just try to flex and extend the forearm from the elbow joint, right? But first and foremost thing is you have to tell the person, for example the patient, please relax, to relax all their muscles. And after their relaxation only, if they are not relaxed, they will tighten their muscles. Then what you are doing is not something passive. Then to elicit it in a very passive way, you have to ask them to like relax, right? And from your strength, not from their strength, that you are going to move the hand. You can do it for the same for the lower limbs as well. If you do that, if the tone is high, you can see the resistance is bit higher, right? And if the person you are sitting in the tone is normal, you can understand. For this you have to check tone in several people. Then you can understand what the normal tone is like. And then you can understand what is flaccidity or flaccid. That is, the tone is diminished, tone is reduced. There's not much resistance to stretch. You can move it very readily, right? And hypertonic or spastic. For example, a patient after a paralysis, after some time, they develop spasticity, where you can't move the limbs very passively. When you move, you can move the limbs passively, but there's a great resistance against that compared to what is normal. So that is what is called tone and flaccidity and spasticity. Okay. So muscle tone is also elicited, is kept by mainly by the stretch reflex, which is the postural reflex. That means the tone can be changed by the activity of various pathways that descends to excite alpha or gamma motor neurons, which are coming maybe from up. That's what I told you before, that if there's a stroke, right? If there's a stroke, then the corticospinal tract, it is affecting the corticospinal tract impulses, so that their inhibition from the cortex is reduced, so that the muscles will be contracting from the spontaneous impulses of the alpha motor neuron, because the stimulatory responses are more prominent now because inhibition is reduced, so that it is basically there's much more contracted state in the muscle than before, which makes its tone higher, right? So, what are these upper motor neurons? What are these lower motor neurons? So, upper motor neurons, if you think about the usual motor neuron system, you know it is starting from the motor cortex, and different levels they come and then relay with the lower motor neurons. So, in the uppermost areas from the brainstem, out come these lower motor neurons. So, these are the upper motor neurons, and there's a ganglion or nuclei, from which a lower motor neuron is starting. So, these are mainly cranial nerves. These lower motor nerves, we call them usually cranial nerves. And their upper tract, we call them corticobulbar pathways. And these others which are ending up in the spinal tract and then relay with the motor neuron here, we call them corticospinal tracts. And coming out is the alpha motor neuron, right? So, if there's an issue on the upper motor neurons, that means these corticobulbar tracts, corticospinal tracts, then we call them usually upper motor neuron lesions. Whereas, starting from the anterior horn cell, the lower motor neuron or the neuromuscular junction or the muscles are affected, then we basically call them lower motor neuron lesion. Just to show you an example. So, you learned in stretch reflex, right? You learned in stretch reflex that after the patellar region is tapped here, there will be what is called a knee jerk. So, you should tap so many patients when you start your clinicals, then you know what the normal patellar reflex is like or normal knee jerk is like, right? For example, if there's a issue in the corticospinal tract, if there's a lesion, the slight inhibition, which is usually exerted by the corticospinal tracts towards this contraction of the muscle here, femoral muscle here, is inhibited. The inhibitory impulse is not there, so that more stimulatory pathways are predominant. So that when you tap this, the outcoming response from the motor neuron will be much higher, right? So you know how you assess that, the movement of the leg, the rotatory movement, how it goes up. Say if it's coming like this normally, now it's going too far because now there's a lesion in the corticospinal tract, and this is very more stimulatory or more contraction, more like the impulse is more stimulatory now, and because this inhibition is diminished. So compare in an easier way in a table upper motor neuron weaknesses and lower motor neuron weakness, how it is going to manifest in a patient, right? And when you go to the patient, when you start clinicals, when you just ask them to show you their hands or maybe just legs, you can see, if you can compare it with a normal person, that in some of these patients, they have muscle wasting. So if you see muscle wasting in a patient, right, it is mainly a lower motor neuron weakness. In upper motor neuron weakness, it is very rare to see muscle wasting, right? But if they don't use a limb for a long time, for example, there was a stroke. So the problem is in the cortex. It's a cortical lesion. So it's an upper motor neuron lesion. So after some time, right, when they don't use the muscles for a long time, right, years, they are not using that muscles properly, it would lead to what is called disuse atrophy. When somebody is not using something properly, it leads to reduction in the cell size, and which will lead to atrophy, reduction in the cell size of the muscles. So if there's muscle atrophy in upper motor neuron weakness, that is due to that means that person has not done good physiotherapy, right? And has not used the limb for a long time. But for the time being, before you see that type of patients at your level, you should know that wasting is not a feature of upper motor neuron weakness. And then you can carefully look at the patient's limbs as well as the tongue, right? Which in those places you can clearly see what is called fasciculations if it is present. It is kind of irregular contractions here and there, very haphazardly, and it is mainly because of the denervation of the muscles, and you know the wasting is also due to the same reason. And fasciculations you would not see in upper motor neuron weakness. So I advise you to do this at this point. You can check in YouTube. Just put it as fasciculations of tongue, fasciculations of limbs, and then you can see nice fasciculations, which is a learning experience for you. And then what is tone? Now we discussed about tone already. So when somebody is checking tone, that means the resistance to stretch. And if it is very readily movable limb, we call it hypotonic, and that is usually coming up with a lower motor neuron weakness. And then with upper motor neuron weakness, what you see is a spastic or higher tone, and you can see what is called a clasp knife quality spasticity, which means when you move the limb passively, initially there's lots of resistance, and with movement then it suddenly gives way, just like a clasp knife. And you can also see clonus. So how do you elicit clonus? Just look at a video how they are eliciting clonus. So clonus is done in First, what you do is you slowly plant a flex and then suddenly dorsiflex the leg. Leg means foot from the ankle joint. Plant a flex and then suddenly dorsiflex. Then you can see nice oscillatory type of movement of the foot, which is called a clonus. That is elicited. That's the way the clonus is elicited, right? So clonus is seen with hypertonic only in the hypertonic muscles. So you can't see clonus in lower motor neuron lesions. And the other point I mentioned here is there's a state of neural shock in any kind of lesions. For example, after a higher spinal cord injury, or after a stroke, after a bleeding to brain, right? Initial stage, it can last days to maybe 1 or 2 weeks sometimes. Initial stage, the hypertonicity would not be there. There will be initially kind of very weak muscles and low tone and things. But later on only, they will develop increased tone. And also, these reflexes are also initially diminished. But once the spinal shock stage is gone, then thereafter, throughout, the tendon reflexes are exaggerated and the tone will be high, right? So reflexes, what happened to the reflexes? The tendon reflexes are exaggerated. What are the tendon reflexes we are eliciting? So you can learn them when we are doing the practicals, but you can check them in YouTube now itself if you are interested. So tendons are usually exaggerated. First, see what the normal reflex is like, tapping with a knee hammer, and then what it is exaggerated means. You can see it very prominently. The result of after tapping the tendon is higher than normal. And if that's a lower motor neuron lesion, then after tapping with the tendon, there won't be any kind of movement, or maybe it is depressed. It is there but very hardly seen. For example, you can only see the contraction of the extensor muscles, the femoral muscles over the thigh, but you can't see the movement of the leg. That is depressed reflex. And also the plantar response. You can check it in YouTube. Usually plantar response or Babinski is done using a khaki, which is the best one, which is not very sharp, and the best way to elicit is using that type of instrument. And what you will see in an upper motor neuron lesion, fanning of toes with big toe going up, and if it is absent, the toe will come down, and that is a normal plantar response. So Babinski sign can be present or absent, right? So these are the two postures I told you before, two very pathological postures. Actually, you might be able to see these patients when you start doing clinicals. So there are two types of lesions mainly with different posturings: decortication and decerebration. What is meant by decortication is mainly the injury is to the cerebral cortex. So for example, what in a like say, if the whole cerebral cortex is affected by a lesion. So now the basal ganglia and brainstem are intact, and the cortex inhibitory impulses are no longer there to giving an inhibitory impulse. So that the gamma motor neuron discharge is increased, that is alpha motor neuron discharge is also increased, producing what is called decorticate rigidity. In decerebration, It is a complete transection of the brainstem between superior and inferior colliculus. Now you can see the brainstem pathways are functioning independently, but there are the basal ganglion pathways there which cannot act as what we can see in decorticate posture. So you can see in decerebration mainly hyperactivity in extensor muscles in all four extremities. And this spasticity is due to facilitation of the stretch reflex. So this is trying to show you, so if there's a resection at this area, it will show a decorticate posturing. And if the resection is around this region, it will show a decerebrate posturing. So just to show you, so decorticate, so I told you decerebrate on, you can see all four limbs are extensed because the rubrospinal tract is sectioned. But here, since the red nucleus, coming from the red nucleus, the rubrospinal tracts are intact. So these hands are flexed with that aid. So you can see flexed hands with extended legs. Okay. So this part is much more interesting. What is gait and different gaits. And I advise you to refer to videos in the YouTube to learn this further. So what is normal gait? You know, if you think about the gaits of the people you know, all the people have their own rhythm of walking. And some people you feel like they have a bit of abnormal gaits. And still, if these features are there, you can call it a normal gait. The person should be erect, which we think all should be as humans. And the steps should be moderately sized, not very long steps or very steps that are very close together. And the medial malleoli of the tibia, right, which come from this region, should have a straight line. You should trace a straight line like this. So you can check this if you come with water or ink, and if you can walk around, and you can see whether there's a straight line for your gait. So when somebody is walking forward, usually there's a hip flexion, knee flexion, and ankle dorsiflexion. So for example, if all these higher functions, muscle contractions, all these things are okay, but if still there's a joint issue, any kind of muscle issue, local muscle issues, or anything like that, that could also change the gait. Okay, and the coordination, mainly done by the cerebellum, ensures the fluidity of the movement, right? So if you are assessing a gait of a patient, which you can do it today itself, not a patient, somebody that you can assess the gait. What you are doing is, first you ask them to walk around. So in the ward, we usually ask them to, okay, ara dora gawata gihilla aime haralena, just a long way that we ask them to walk. If just make sure that they are not falling. Some people are tend to fall. So make sure they are not falling. If they are not falling, you can ask them to go there and come back. And also if they are wearing a sarong or big skirt or whatever, you have to keep them at least up to the knee level so that you can see how they walk properly. And then you have to ask them to do what is called heel to toe walking. That is, you can either ask them to walk along a line, like straight line, while keeping your first heel, then toe, and then again the heel of the other limb, then toe. Likewise, like heel to toe on a line. And the other test you can perform is what is called Romberg's test. What is this Romberg's test? Look at this picture. Just try to understand the picture. So you can see somebody's eyes are opened and then closed, right? So what we ask the patient to do is, first, always make sure that they would not fall, their safety. Ask the patient to keep the legs closer and stay in the upright position. සීරුවෙන් ඉන්න කියන්නේ අපි patients ට we can ask like that. And now their eyes are open and you ask them to stand upright. While they are standing, say if they are okay standing like this, confidently doing that, looks okay, that's fine. Say if they are very unsteady and this just shivering, moving like, then you should be extra careful when you ask them to close the eyes at the same position. Then it will make them more wobbly and they can even fall. So just make sure they are not falling. So some patients were initially also wobbly like this, but when they close their eyes, they become more wobbly. But there are some patients who are confidently standing like this, but their stance become very unsteady when they close their eyes. What is the underlying reason for this? This is because, for posture, there's a good input from vision. So here, they have an issue with the proprioceptions or maybe sensory receptors over this region, legs. So it is initially not visible because the vision is compensating, but once they close their eyes, it cannot be compensated and they are unstable, right? And here, they are already unstable. Vision has some compensation, but once the eyes are closed, they can't compensate us at all. So it seems like this is due to cerebellar lesions, and cerebellar usually because the proprioceptions are there, still without the cerebellum, you are unsteady even when your eyes are open and you become more unsteady like this. But you can differentiate sensory ataxia from cerebellar ataxia by doing this Romberg sign, right? Yes. So I advise you to go to YouTube and check how they are checking the Romberg sign and what is a Romberg's positive patient looks like. And then type hemiplegic gait or upper motor neuron weakness gait. Then you can see how they walk. So these patients usually, so upper motor neuron weakness, just think that this patient could have a left-sided stroke causing right-sided upper limb and lower limb weakness. So this is upper motor neuron lesion. They are spastic. The leg is extended. Hand is a bit flexed, right? And if you ask them to walk, their toes here force downwards. So when walking, they have to clear these toes, but because of the spasticity, they can't move them way up. So what they do is they circumduct this limb from the hip, right? Circumduct, like abduct and circumduct, and take the limb around the hip to prevent toes from catching the ground, right? So there are paraplegic patients. So paraplegic patients are mostly seen with what is called cerebral palsy. So cerebral palsy is a condition seen in children. So it is a result of usually hypoxia during intrauterine life or during birth, during the birth, postpartum period, or maybe after that, immediately after that. So when somebody develops cerebral palsy, they can have diplegias, monoplegias, but they are mostly, what you can see is that they have what is called paraplegias. That is, both lower limbs are affected and they are spastic. Since they are very spastic and they have strong adductors over the hips, when they are walking, their posture is like a scissor. They're scissoring, you can see it properly, right? So if you see a video, you can understand this. Parkinson's disease is quite common disorder among elderly people, and it is what is called a degenerative disorder. What is degenerative disorder? Wear and tear. Even a, let's say, if you buy a good like a chair or furniture, whatever, with time they wear and tear. The things degenerate. So likewise, even the human body, they have degenerative issues, and Parkinson disease is one of them. And it is thought that it is due to reduction in dopamine, which is a neurotransmitter in the region of substantia nigra. So because of this, there are several features these patients would have. So if you just ask them to, okay, button up your shirt, you can see how slowly they start doing that, right? It will take so long for them to reach the button and then find the buttonhole, and it will be very difficult to put it in. And Parkinson's patients, if you see them at rest, you can see what is called pill rolling type of movement. So they have tremors, right? And if you see, they have like always from the thumb, they are rolling a pill like of movement. And if you see them walking, which is the main thing we are concerned here, their gait, it's very difficult for them to start or initiate the walk. That means they have a lot of inertia, right? Avasthitiya ready, start something, it's difficult. And once started, uh, they lean forward and then hurries a lot. They're walking faster than us. Like when they have to have a like very rhythmic, small, like very slow walk, they start and then they walk very fast. Not very fast, I mean they are walking faster than usual. And then it's difficult for them to turn around. If you ask them to turn around, they will freeze. Right there. They will freeze there. And slowly they will turn around. And usually they keep flexed and a stooped posture, and their steps are very short and they're very shuffling, right? Moving to either sides and very short steps. And since the population is aging, you will see more patients with Parkinson's in the future. I hope you will see videos uh, to understand these things that I'm trying to describe you. Just refer to videos. So what happens with lower motor neuron lesions? We have learnt about lots of upper motor neuron type of lesions. And what would happen with lower motor neuron lesions? So if you think about the gait, what comes to your mind with lower limbs? Is mainly a foot drop, isn't it? Just think about common peroneal nerve palsy, right? Or maybe a weakness in the L4, 5 levels, right? And these things would lead to what is called foot drop, which is mainly seen as lower motor neuron weakness. But the weakness could be due to many other reasons as well. And the weakness could be in the muscles, neuromuscular junction, like in myasthenia gravis. But mainly what you see as low motor neuron lesions are mainly the toes are coming downwards and just foot drop. So when somebody has a foot drop, the limb need to be lifted up to clear the ground all the time. So if you see it in a patient, we call it a steppage gait. If one limb is affected, they have to lift the leg up and come down. And if it's bilateral, when they are lifting both legs very up, and then when from the ground and when they are hitting the ground again, it usually resembles a horse. It's like a horse. The horse, how they walk, and it looks like that. So what is this waddling gait? This waddling gait is mainly seen in muscle weakness, myopathy. What is myopathy? It's weakness in muscles. So myopathy can be due to various reasons, and mostly it is congenital. So in muscle diseases, like isolated muscle diseases like myopathies, where the weakness is mainly seen in muscles, um, the nerves are, it's not the nerve per se, it's the muscle is affected. Usually it is towards proximal muscles. Maybe the proximal muscles are wasted. You can see the reflexes are absent, as well as you can see when they stand up, it's very difficult for them to stand up from a sitting position, because mainly when you stand up from a sitting position, it needs proximal muscles, right? And when they're walking, since the pelvic muscle weakness is there, it is difficult to fixate the pelvis like normal people. They sway back, like, and also their bellies, the tummy is coming out like a pot belly, and their pelvis will waddle or move from side to side, and they show a very characteristic type of walking. Okay, moving to the other side. It's ataxia. So ataxia means an uncoordinated movement. So this uncoordinated movement, the easiest way to understand this is, just remember a drunken person who is heavily drunken, who can't walk properly, who is falling down, and you think that the rate they walk is not nice, their range, their force, direction, everything is affected, right? So ataxic gait is a wide based gait. If you check the distance between the feet, you can see they are wide apart, as well as they're very unsteady, right? They're kind of waiting to fall type of patients. So you have to be very careful when you ask them to walk there and come back. They might fall in between and might injure. And it's not only for gait that we use this word ataxia. So ataxia is an erroneous way of doing things, uncoordinated movements. So it's not only in the walking style that you can detect this, but also in speech. The people with ataxic speech are slurry when they speak. For example, if there's a lesion in the cerebellum, they will have very slurry scanning type of speech. So in clinical sense, what we usually ask patients to say is Prajatantravadaya, which is a very difficult word to say. When you ask them to say Prajatantravadaya, they might say Praja. So there will be lots of slurring and scanning, right? Prajatantra. So that shows there could be a problem in the cerebellum. As well as what the Sudha fellows, so in the other countries, what they do is they usually ask them to say baby hippopotamus, which they think a difficult way to pronounce. So these words are used especially to see how they articulate. And then these ataxias, many types are hereditary. Even though they are hereditary, or they are after an acquired lesion like a tumor, still they can be categorized into three main types according to the site of origin. Even you can assume now that if there's a lesion in the cerebellum, it can lead to ataxia. Or if there's a sensory issue like proprioception mainly, it can lead to ataxia. And then vestibular. So all these things are, they are the sensory impulses which are coming to handle the posture, which are trying to correct the postures. So if the postural corrections are not there with the problems or issues of these things, then the person will be ataxic. And their ataxia will manifest not only from the gait, but by speech, especially in cerebellar lesions. Speech ataxia is not a feature of proprioception, that you know. It is only seen in cerebellar lesions, but otherwise, ataxia can be, like per se, the ataxic gait can be seen in all these three types of patients. So how to differentiate cerebellar ataxia from sensory ataxia? So we learned by doing the Romberg sign, you can easily differentiate these two patients. But though we say like that, it's not really easy. That's why we need imaging. Doing a CT scan, doing MRI scan, right? But like if you have a good clinical sense, if you want to see these patients, examine them and come into a diagnosis, you can ask them to walk around, right? You can ask them to stand still upright to check the Romberg sign. And you can ask them to do heel toe walking, and you can check other cerebellar signs, right? So when they stand and walk, cerebellar patients, their feet are separated widely, and then they can fall to one or both sides. So for example, if they are mostly falling towards left side all the time, the cerebellar lesion is most commonly on left side. Because the cerebellar system, the tracts are coming, they are not usually decussating, they are coming towards the same side. And in sensory ataxia, they are trying to keep the legs very, hard on the surface. Stamping, right? Just to keep the legs like an elephant stamping feet, right? And keep the legs on the ground because they are aware that their proprioceptions are not the best. For example, in the patients with diabetes mellitus, what is the first thing to go? Usually the proprioception. First the vibration and then the proprioception they will lose. So that they tend to fall as well as they are trying to stamp their feet on the ground. So I think you know that these afferent pathways are going through the posterior column. So if there's a lesion in the posterior column, that will give rise to sensory ataxia. One example is B12 deficiency. So these are some of the references. There were many more which I could not mention here. So it is not a direct reading through the Ganons to come across all these problems and issues. But as a medical student even, we were very interested in this neurology and neurosurgery illustrated book. Maybe not for you at this level, but it's very simple. If you can read it, if you can download the PDF, you can see the things there are very simple and precise, but it's a more like a clinical book. So it just give lots of clinical things rather than they're not trying very much to explain things physiologically. So but still I advise you, even if it's not this level, later on to read neurology from Neurology and Neurosurgery Illustrated. Okay, thank you very much for listening, and we'll meet up with EEG and sleep lectures. Thank you.